Welcome everyone. I'm Helen Kent Davis. I am a senior policy advisor for the Texas Primary Care Consortium. And today is our webinar, Primary Care at a Crossroads, Navigating Recent Policy, Budget, and Regulatory Changes. We are so happy to have you all here. One primary goal of the consortium is to build connections across the primary care landscape. And today, represented on the call, we have a lot of diverse perspectives and stakeholders involved in that discussion, everyone from the legislature to academia to private practicing clinicians to state agencies. So we welcome you all for taking time to be here and engaging this important conversation. It's especially timely today because this is actually National Primary Care Week. So we are here to celebrate all that primary care does for our healthcare delivery system, but also for the individuals who get care in a primary care practice and its importance. When we're going to talk a little bit more about that later with our esteemed guest, who I'm very excited to talk to, Dr. Russell Cole and Stephanie Quinn, who I wanted to name a doctor. She could be. She knows the healthcare delivery space as that well. So again, thank you. So if you're not familiar with the consortium, we invite you to look at our website. We have numerous resources there, including a fantastic dashboard that has resources about primary care in counties across the state. And this dashboard is actually going to be updated. There's going to be a new version of it launched at our summit, which is coming up at the end of October on the 23rd and 24th. So if you're not registered for the summit, please do so. And our wonderful TPCC staff will post a link in the chat for you to do that if you haven't already. But the Texas Primary Care Consortium is all about how do we advance high quality primary care for every Texan, co-led by the Texas Health Institute and the Texas Medical Home Initiative. We've existed for more than 10 years, and we're excited about our opportunities to continue building this unique work that we do. I'm going to move on. So one thing that we're going to talk about today is sort of an icebreaker as part of our National Primary Care Week is why primary care matters to you. And obviously, if you're here on this webinar, it does matter. And I'm going to ask first Dr. Cole to answer that question. We are actually going to be, today it's already launched on LinkedIn. If you're following Texas Primary Care Consortium there, that is the question posted. And we want you to answer it as well, everybody on this call, and then to tag somebody else you know who would also be interested in answering that question as our part of our efforts to elevate primary care. So Dr. Cole, as a primary care physician who has not only practiced as an actual clinician seeing patients and now is helping to reshape the healthcare delivery system, tell us why primary care matters so much to you.
Sure. Well, as a family physician, being a primary care physician is the type of doctor that everyone wrote about in their essays of why they wanted to go to medical school. When you talk about the old ideas of Barbara Starfield, you want to be that doctor that has the relationship. You want to be a friend who is well educated, knowledgeable, compassionate, that they can bring their problems to, and you get to give the explanation. It's what makes primary care beautiful, but it's also what makes it really hard to do well. But that's it. We're the doctors everyone dreamed about being.
Well, we thank you for choosing primary care and for continuing to tout it. It is absolutely essential to having a cost-effective, high-quality healthcare system, and also to just ensuring that patients get the care they need. Stephanie, you as at the American Academy of Family Physicians, which has, I guess, prompted the National Primary Care Week and is very instrumental in organizing it. Tell us why primary care matters so much to you.
Sure. Most of my career has been spent in health policy, first on the insurance side. And I think, if you look across the delivery system, most things tie back to primary care. And I think if you look at a strong primary care infrastructure, I think it contributes to the solution of a whole lot of problems that we have in our healthcare system. And so it's just, for me, it's really cool to see the power that a sound primary care infrastructure can provide to the health of our communities. So for wanting to be a doctor and not being able to follow through on that, this is the second best thing.
Yeah, so I'm with you on that. I had no interest in going to medical school myself, but I too care a lot about primary care. When I was growing up in West Texas, my grandparents lived in a rural part of the state, and we had a primary care physician who not only had delivered my father and my aunt, but took care of me when I was visiting my grandmother, along with 7 other grandkids. She was fabulous, very direct, no nonsense kind of physician. But we all loved her and just appreciated her dedication to our family through the best times and not so great times in terms of health. And she's that's when I think of primary care. I think of her. She not only took care of us, but occasionally was called in to deliver little baby cows, or as growing up on a ranch. That's what you do in West Texas. As a primary care physician, you put on your overalls and you take care of whatever kind of animals you need to. Well, thank you so much. And I didn't actually mention, I neglected to actually officially introduce you both, which I will do now. So Stephanie is with the American Academy of Family Physicians. As I mentioned, she's a senior vice president for external affairs and practice experience, and she has extensive experience working in primary care, as she mentioned, but also in Washington, D.C., working on legislation, advancing primary care and the healthcare delivery system. So she's going to be very helpful in talking about our primary topic today, the One Big Beautiful Bill, which I will refer to as OB3. And then Dr. Cole, Russell Cole, who's a chief medical officer and chief operating officer at the Texas TMF Health Quality Institute, and also is a previous practicing physician, but still the Surgeon General in the Missouri National Guard, as I understand it. So my husband grew up in Missouri, so appreciate your service there, and also to Texans and the other states that are in TMF's umbrella. So we're going to get started. One thing I just want to make is a housekeeping note. You all heard that this is being recorded. If you have questions, put those in the Q&A. We will stop periodically and take a few from the audience. We won't hold them all to the end, but we really want your feedback and hear from you. So please put those in the Q&A. We also today are going to focus on OB3. We had initially, when we organized this webinar, had intended to also cover some of the accomplishments at the Texas legislature this year. But OB3 is such a massive bill, and it has such a presence in everyone's mind right now, since it's getting a lot of attention with the budget discussions in Washington and shutdown. We wanted to shift focus and just focus on that. We will be posting an update on Texas legislature and our primary care wins and a few setbacks. And when that's available, we'll send that out to you as a resource guide. Again, the website is a great resource for a lot of things that we're working on. But today we're just going to focus on OB3. So with that, I also want to thank our partners who helped produce this webinar: the Episcopal Health Foundation, the Texas Academy of Family Physicians, some of whom are the leadership of which is in the AAFP conference right now, where Stephanie is, as is Dr. Cole, the Texas Association of Health Plans, and the TMF Health Quality Institute. So thank you all for your generous support. All right, so we're going to with OB3, many of you here have been reading about it. I think understand its broad implications, and that's what we're going to focus on. We're not going to get into the weeds on all the healthcare provisions. It's extensive changes in healthcare delivery. We're going to also focus on some pieces of the bill that have gotten less attention, but that will have implications for primary care. I think the main thing to think about is just the amount of money we're talking about that the bill will achieve over 10 years in terms of cuts. Some people see them as savings. It's $1.1 trillion over 10 years. And this does have implications for all healthcare programs, Medicaid, the Children's Health Insurance Program, Medicare, and the Marketplace. When I was thinking about $1 trillion is really hard to imagine. Most people don't have any concept of that. But to count to 1 billion you can do in a decade. To count to $1 trillion, it would take you more than 30,000 years. So massive amount of money coming out of the healthcare system. So that is going to require some innovation in terms of how the primary care system adapts. The changes will be achieved through a variety of administrative eligibility and programmatic financing changes. It's not like for most part, not exclusively, but not direct cuts per se. It's just how do you, in some cases, make it harder for people to enroll and keep their healthcare coverage versus just a direct cut, though there are certain populations who also now be excluded from eligibility from certain programs. It's important to note that many of the changes in the bill apply to Medicaid expansion states. Texas is not one of those. So those changes do not apply here, including Medicaid work requirements, which were getting a lot of attention by the media when the bill was being debated, but those do not apply here. Where Texas will be most impacted is via changes to the Affordable Care Act marketplace eligibility, as well as the potential, should it happen, any Medicare cuts that would come about from sequestration, which we're also going to talk about. The bill does stagger implementation of the various provisions over the decade, with the exception of some really big ones, which you're all hearing about, including extension of the premium tax credits, which will expire at the end of this year if Congress does not come to agreement on those. So very broadly, these are the buckets where the OB3 makes changes for healthcare. The bill was obviously a much bigger than healthcare. It affects everything from energy and the environment to tax reform. So we're just obviously focusing on the healthcare implications. And some of the changes are ones that people support, including the $50 billion funding for the rural health transformation. Texas is in the process of putting together its application, which is due to CMS in early November. So that's a positive development. And one of the things we're also going to spend a little bit of time talking about is the new focus on direct primary care. Direct primary care is a little bit different than concierge medicine, and this is something a lot of primary care practices have been supporting for years to find a way to use it more easily. And Dr. Cole will be talking a little bit about that in a minute. The ACA changes, I'm not going to go through everything on this slide, just by the way, and we will share these with you. You're hearing about in the news right now, it is the fight over extension of the enhanced premium tax credits. If those are not extended, Texas is a state that has seen rapid growth in ACA enrollment, and estimates are that people's costs could more than double in some cases. For older folks who have incomes above 400% of poverty, right now we have a provision as a result of the enhanced premium tax credits that means that they don't pay more than 8.5% of their income. That would just go away. So just a huge jump in cost, meaning a lot of people will exit coverage because they just won't be able to afford it. Changes in the open enrollment period, as well as eligibility for certainly lawfully present immigrants, among other changes to the enrollment piece. Some of these changes were achieved via the ACA regulations that have been implemented by CMS. We're, again, not going to go into great detail of these. A lot of these are very wonky. If you have questions about them, we'll do our best to answer them. Medicaid and CHIP, Texas largely escaped the worst of the changes in the bill. Medicaid expansion states are already in the process of implementing reforms to their eligibility systems so that they can check whether people comply with the work provisions. We don't have those, so that's positive. The Medicaid retroactive coverage is another one that will impact Texas, though. Right now, people, when they enroll in Medicaid, if they've had previous healthcare costs of services are covered by Medicaid, we got 3 months retroactive coverage. that will ultimately change to 2. It'll be shorter in expansion states to 1. And then there's also changes in the way that states can finance Medicaid through limitations on provider taxes and supplemental payments, which we're also not going to spend a lot of time on. The good news is on the Medicare front is there is a 1-year payment increase, which is desperately needed. And we hope that that will be extended beyond the 1 year in future discussions about healthcare. But Medicare also, we will see some changes in terms of lawfully present immigrants who will no longer be eligible, and some other restrictions on the application of the Medicare Savings Program. These are for people who are duly eligible, and the simplification measures that were put in place via rule under the previous administration, the Biden administration, those will not be moving forward. Obviously, Congress can still act to extend the premium tax credits, as well as address Medicare sequestration, which will get triggered at the beginning of the year if they do not. This is just broadly speaking, the timeline. I'm not going to go through every one of these. As I mentioned, it phases in over several years, extending in some cases well beyond 2027 when some of the changes will be made. So ACA enrollment growth, as I've noted, this is where Texas has seen the most gain in terms of health insurance coverage, 255% increase over the last 5 years, which is really phenomenal. We're now about 4 million Texans who benefit from coverage in the ACA. And according to our supporters of Physical Health Foundation, when you look at just the implications of not extending the enhanced premium tax credits, not all the other changes that were affect marketplace enrollment, just these, we're talking about anywhere from 665,000 to nearly 1.5 million Texans losing coverage, mostly because they'll just not be able to afford it and will drop out. So that's pretty significant in the next year. So with that, I think that's my last slide for that one. No, I'm sorry, I take it back. One of the things we are going to talk about, again, I'm not going to go into this in a lot of detail. We know that the bill is going to have significant impact, some adverse, some positive. Higher rates of uninsured mean more people use the emergency department. We have higher rates of uncompensated care. Already health insurers are increasing their premiums in anticipation in the marketplace of having fewer healthy people in the risk pool. That will also have effects on the broader healthcare insurance marketplace. Mission-driven initiatives, I was asked recently by someone about how they're going to sustain some of their efforts around outreach to pregnant moms, things they're doing on their own. Doing work in the maternity care space is often a loss leader. And so how do you maintain this? The impact on the workforce, the budget bill does restrict how much loan repayment physicians and other professionals can take out. At the same time, we know primary care is extremely adroit and adaptable to changing circumstances, and they did that during COVID on a dime. Primary care clinicians pivoted to provide telemedicine services, virtual care. And this, as a result of these broad changes in the landscape, might cause changes that are positive, not all negative. And so we have to use this change to spark our most creative brains responding to what's going to be a lot of uncertainty and some upheaval. So with that, I'm going to stop, and I'm going to start off with some questions first with Dr. Cole before we pivot to some questions from the audience. I always think it's important to hear from somebody who's taking care of patients about what it really means to have insurance or be uninsured. And you've been in that space and you know what it means in terms of not only their access to primary care services, but other services they need to get and stay healthy. So could you just talk about, from a physician perspective, what it means and the health outcomes when people don't have health insurance?
Sure. There have been a whole lot of people who have pontificated on what the implications of having health insurance, not having health insurance, all those. As a physician, I like to go back to the literature and see, what do we actually know? There was an interesting study published in 2024 out of BMJ that actually was able to do a randomized controlled study on the impacts of availability of health insurance. And what they found actually is that in the short term, the primary impact is access to care. Now, one of the interesting things is, we're not necessarily trying to just get access to care. We're trying to get people better healthcare outcomes. That's one of the challenges of a short-term study, is to be able to say, okay, so in 1 year or 2 years, did they have better outcomes? What interestingly they could find in the study is they could show better mental health outcomes in patients with health insurance at just 1 to 2 years of insurance. They found more folks who had received preventative services, who had been identified as having early stages diseases that we could actually start doing something about from a preventative standpoint. At TMF for over 50 years as the Medicare Quality Improvement Organization, our responsibility is to work across the entire continuum of care. So from home health to nursing homes to hospitals to physician offices, and to do that by thinking about the beneficiary specifically and how that person moves through the healthcare system and how that works. I think it's important when we talk about health insurance to recognize that, it's not just a piece of information on a paper. It's how a person thinks about their relationship with the healthcare system. And so even a Medicare beneficiary who has health insurance, if they don't understand or have access to the care that they need, then they're not able to actually achieve health. And that's really the important aspect of it, is how do we make sure that people with or without health insurance aren't in a situation where they have to self-regulate. We all know stories of folks who have health insurance but don't have a copay, or have health insurance but have to drive an hour and a half to find somebody who accepts it. I think the real issue we have to focus on is, do people have access to care? And is the care that they're able to access the care that they actually need?
And I might add on to that, just the what's, when you destabilize a risk pool and coverage goes out of reach for some folks, what you see is only the higher cost, higher need individuals stay in because they know they have to receive care. And so those healthier people that are subsidizing it and making it affordable and accessible for others leave because they're not in need at that time. And so I think many of these provisions, we may see a destabilization of the risk pool, and so that drives up costs for everyone, and not to mention, we'll see some poorer outcomes as a result. So I think those are the two factors. There's the individual access because of the behavioral economics that come with a lack of access to coverage, but then the overall concentration of a sicker risk pool.
Yeah, I like to think about healthcare finance a bit like trying to squeeze Jello in your hand. You can squeeze tighter, but if you don't pay for the preventative care, you're going to still pay for it down the road with much more expensive acute care and uncompensated, or I'm sorry, care of more chronic diseases that are at a further stage of degradation.
So that's important because when you think about the administration, one thing they're very focused on, a positive, is increasing preventive care and trying to address chronic diseases earlier through prevention, early detection, and better management. So obviously health insurance alone is not the only contributor to access. There's lots of components to that. But as you're thinking about the response to, what's happening on the number of uninsured, but we're also trying to do better at addressing preventive healthcare. How do we do that? That's going to be, it puts everybody in a little bit of a pickle. But again, getting back to, what that might spark in the healthcare delivery space, trying to be more creative about how we reach those populations.
Yeah, Helen, I would just say, going back to the comment that you made earlier about the adaptability of primary care, I think as we're thinking through the discussion, you can find hundreds of articles and recordings in that about, what are the exact impacts likely to be of OB3. I think the real question for folks is, all right, so this is the reality that we are faced with today. How does primary care move forward? What is it that we can do about it? And recognizing that okay, maybe what got us to here is not what's going to get us to there. And so how do we leverage that adaptability of primary care to say, okay, maybe we need to rethink how we do some of this. This is one of the things that we're working on. We know that from some of the implications, for Texas itself, we know from a recent study that there are about 84 hospitals at risk of closure in the next 3 to 5 years, and there's another 21 that are at risk in the next 1 to 2 years of closure. Okay, well, the question that faces us is, you can take the question as, how do we shore up those hospitals? Or you can take a slightly different question and say, okay, what is the care that those communities need? Is there an opportunity for us to rethink about maybe hospital at home is not just an urban option? Maybe we're able to implement hospital at home in more rural areas. Maybe we're able to use mobile integrated healthcare. Some of the pilot projects that have been done across rural Texas about how you can leverage volunteer fire departments, how do you leverage the ambulance service, all that. Take that more patient-focused perspective on how do we provide the care that folks need. I think that's the adaptability that this is going to put us in a position to simply have to be able to do.
So, Stephanie, you have a background working not just with AAP, but with a health plan. And so I think what Dr. Cole is saying is important. You're really going to have initiatives where payers and clinicians and community leaders come together to address not only the access to care for people who have insurance, the cost of care, but also those who are uninsured. So is this something like as AAFP looks ahead, and with your experience and just delivery system transformation, just perhaps creating new delivery models or provider types that could move into this space, and to use this moment to think more creatively about how care gets delivered with, since we are going to see, even with the bill hadn't passed, we have a lot of really vulnerable hospitals and rural health systems.
Yeah, I mean, I think there has been a lot of encouraging innovation, multi-stakeholder innovation over the past few years. And I do believe that that's the key. I don't believe that it's going to be government programs only, moving forward in innovative ways, or commercial programs only. And I think some of the models that we had seen previously, making care primary being one that they've halted. I think what was really important about it is that it was payer agnostic, and it was really trying to get at, how do you get all payers rowing in the same direction? They're all contributing resources in one way or another to these communities. And I think that's the biggest threat right now with this bill, is that it really chokes off a lot of the financing, and in many states creates some new administrative requirements, and those cost money to implement. And so what's likely going to happen is you're going to be shifting some dollars away that may have been allocated for resources and services over to implementing administrative processes. And then layered on top of that, you have the uncompensated care that is inevitably going to happen. Just because people don't have coverage does not mean that they don't seek care. And so states are really going to grapple. I mean, I don't know how many state budgets were in the black heading into this year, and they're going to have to find a way to finance that. And, with many of these other mechanisms kind of compromised. So I do think there will be opportunities. I think what's going to happen is people are going to see some of the realities of these put into place. And I think they might come with a renewed interest in looking at different ways to accomplish the policy goal that they were setting out to.
So with that in mind, yes, I think there's definitely going to be budget implications for states, but, from the delivery system perspective, what would be your advice to people on the ground, physicians, FQHCs, hospitals, if you're trying to adapt in this market and you're really going to need each other, each understanding how the other industry is impacted? How do you go about, building this network at a local or regional level that would allow clinicians and communities, facilities to adapt?
Yeah, I mean, there are a lot of encouraging stakeholder collaborations. I mean, most states have a primary care association. Most states, you have the Academy of Family Physicians at a state level, you have the medical societies, you have payer groups. I mean, all the people you flashed on your slides, I think everyone is going to be experiencing the implementation of these requirements differently, and being able to create forums where people can share what that looks like and how things are going will enable people to kind of put their heads together and develop solutions and proposals more quickly, and equip their governors and their state agencies with the data that they need, to firm up some policy requests of the federal government, and to the extent that that's where the solutions lie.
Yeah, and I would just add to that, I think Stephanie really hits the nail on the head with it, but there's a certain degree of artificiality in healthcare policy when it gets down to the actual, physician office. Because a lot of times the policy says, okay, well, this is how Medicare is going to do it, this is how Medicaid's going to do it, this is how each different payer is going to do it. But the reality is, when you're seeing 28 patients a day in the office, you can't really change your process between each patient based on each different payer. And so, the reality of the situation is the office ends up building policies and processes that work for most people. And then that creates that additional administrative burden on top of, okay, how do we put in the spice for this or that payer? All of those sorts of things. I think that's where you're starting to see, and I know we're going to talk a little bit more about some of the DPC sort of movements. I think that really is a big driver of, historically, the DPC movement is primary care docs who are looking and going, you know what, I'm out of the business of guessing what Blue Cross versus United versus Medicare wants. I'm just going to take care of my patients. Here's what it costs essentially to provide primary care, and you guys can deal with the actuarial risk on the back end. I'm going to go a different direction with that. And I think that movement has gained enough traction amongst providers that you see it now, in the legislation itself, clarifying that, okay, the DPC model in and of itself is not health insurance. It is, an agreement between patients and their providers. And so you're gaining some more flexibilities. And I think that truly is a reaction of primary care to the difficult administrative situations that they found them in. And like I said, doctors just saying, I did this to take care of patients, not to figure out which form to fill on a Thursday.
I appreciate that perspective. I want to get into a little bit more about that. I do want to say, just to tout our own horn, TPCC, as an organization committed to bringing together the disparate voices and interests in primary care. It's part of our process at the summit, which we hope everybody will attend, is to start bringing together different parts of the system, employers, physicians, FQHCs, hospitals, others, and thinking about how do we make change in the environment we have, because primary care is very nimble, we know. So that you've got to adapt. Sometimes you walk into the exam room and expecting it to be a simple ear infection, and it's something else. So same thing with this. So appreciate that perspective. So you alluded to the changes in the bill regarding direct primary care. It's not gotten a lot of attention. It is a kind of a wonky thing for people outside of the healthcare space, but it's an important change. Nevertheless, primary care societies have been advocating. So tell us exactly what is direct primary care. Some people associate it with concierge medicine, which is a little bit different. And what are the pros and cons of the changes that are in the bill?
Well, I'll kick off from the clinical perspective and then let Stephanie jump back in on the policy and legal sides of it. But the wonky part of direct primary care is that the reality of taking care of a population of people is there are two different types of risk that drive the cost of that population. There's performance risk, so I, as a family physician, I've got an office, I've got 1,000 people that I need to screen for colon cancer. So how much it's going to cost, what processes I use, whether I'm using, fecal occult blood testing, am I doing colonoscopies, am I doing flexible sigmoidoscopies? Those are all different ways to get to the same goal that have different costs associated. And I have some way of controlling that. What I don't have a way to control as a primary care doc is actuarial risk. This is okay. I've got, this 1,000 patients, and statistics tell me that 30 people out of 1,000 will have a heart attack. Well, I don't have a random sample of patients, and so I may have a population that has a much higher risk simply because of who they are. I don't have a way to adjust my actuarial risk. What direct primary care says is, so I'm not going to try to adjust my actuarial risk. I'm going to take care of your primary care needs. I'm going to establish, here's what my basket of service is. Here's what it costs to do that. And let's just have a direct relationship with that. You see practices that are going back to the old days. When I was in private practice in rural Oklahoma, everyone had my cell phone. The reason was, it's a small town. They're going to call me anyways. I might as well give them the right number to start off with. The direct primary care model does the same sort of thing. It says, we're trying to have a relationship here, and if I can give you advice that takes 5 minutes over the phone and that prevents an ER visit, this is smart care. If I can make arrangements through the lab company that instead of us going through 3 levels of billing and 2 months of expense, if I can pay them directly and you can pay me directly and we're just done with this and we've got the lab results tomorrow at a lower price, that's a smart way of doing business. Let's do that. And so from the clinical perspective, that's really what it looks like, is having more of a relationship directly with your provider. They tend to have lower patient panels so that they can provide that level of service, but it takes a whole lot of those intermediaries out of the relationship between the doctor and the patient. Stephanie, I'll let you talk a little bit more about the legal and technical aspects of it, though.
Yeah, I mean, truly, DPC at its core is a prospective payment model. With a membership fee, it says these are the capabilities that I need to care for a defined population of people, and these things cover the cost of those. And so, without all the quality measurement, reporting, administrative complexities that bog down our system. So in the One Big Beautiful Bill, they have defined that HSA funds can be used to fund direct primary care because it is not deemed as insurance. And so this is a big win for the DPC community because, people could use their HSAs for a whole lot of other things that contribute to health, but not direct primary care. And so that was a really exciting development. I still think there are some details to be work out. I think we're expecting to see some sub-regulatory guidance probably in the next couple of months, looking at what is fair market value. I think Treasury and IRS, who care precious little about patient outcomes or physician experience or any of those things, they're really worried about, is this an appropriate use of tax deferred funds? They are looking at, are things that are included in that membership fee being provided at a discount, or are they being provided at fair market value? And so to give an example, it might be something along the lines of, if you get prescription drugs, in a, at the point of care, this happens in urgent care. I go to urgent care, they give me a Z-Pak, and I use my HSA funds to pay for that. And so we would argue that is an appropriate use of this isn't happening all of the time, so you can use those fees. I think on the downside, one of the things that is a potential downside is, typically they have smaller patient panels so that they can spend the time that they need with those patients. And knowing that we have workforce challenges as it is, and a declining workforce, if you are taking fewer patients, that could begin to ratchet down on access to primary care. And how it's different than concierge is, concierge, you may have a bundle of services where you receive a fee, but they're still billing insurance for the bulk of those services, where DPC is completely separate from that. So I think we're going to see probably a growth of I mean, direct primary care in the sense that it's a 1v1 relationship, or it could be with a practice and an employer. I think we're going to see, because of this new, more permissive policy, we're probably going to see some growth in that area. So that's something that we're tracking.
Great, thank you for that overview. I think that's a part of the bill that, was welcomed by many. It is a big shift. And it's open not just to physicians, but really any kind of clinician, as I understand it. So it will affect broader community than physicians. I don't see any questions in the chat. Or the Q&A. I'm just gonna remind people, if you have questions, please post them in the Q&A. We definitely want your feedback. Also reminding you to register for our summit coming up later this month. Stephanie, you are in DC, and so you kind of have your ear to the ground on what's happening with the debate over the enhanced premium tax credits. So tell us about what's going on with that debate. I know we're still in the middle of a shutdown.
Well, and that's actually why that's a large reason why we're in the middle of a shutdown. I think there had been hope that there had been agreement that these would have been addressed prior to expiring at the end of the year. And I think folks wanted, before the government shut down, for it to be extended through that vehicle. And I think Republicans really wanted to, they wanted to just get a little bit of breathing room, get some appropriations bills passed, get to November 21st, just keep the lights on, clean, and didn't want it bogged down with APTCs. And I think Democrats felt, well, I don't know that we can go with a handshake deal, that you'll address this at a time that later, because we saw a healthcare bill at the end of last year kind of blow up through similar, circumstances. So I think there's a lack of trust. But I will say that Republicans are generally supportive of extending the advanced premium tax credits. I think the challenge is, I don't know that they necessarily agree at the level to which to fund them. You may recall they were set to expire at the end of this year after getting another bump through the Inflation Reduction Act in 2023. And I think some Republicans would like to only extend it a year. I think some may feel 2 years, some might want to reduce the amount of APTCs, and some might want to reduce the eligibility. And so I think before they can, that's a lot to reconcile before December. And I think the challenge is those statements are going to go out. And so even if they have a late breaking deal, open enrollment is upon us. And so the rate shock that people are going to see, I think there will be behaviors associated with that, where they might just forego care that they need altogether, and we'll see poorer outcomes, or they could start stockpiling care in advance, of losing coverage in the beginning of the year. So we could see utilization spikes in Q4 as a result of the uncertainty around this. Not to mention that it's just our typical flu RSV, time frame anyway. So I think there's a lot of uncertainty, and I mean, some of these premiums are going to double potentially if they're not addressed. And so I think plans, when I talk to them, are struggling with, how do I explain that this is, potentially what your premium could be, and this is what it is if they don't address it. And they've been given the latitude to kind of file one, rate notices, one with, one without. But I think it's causing a lot of angst on the patient side, on the physician side, because they're going to be the ones that know that their patients are no longer going to be covered on the payer side. So there's great motivation to address it. I just don't think that they've decided, they've coalesced around a singular approach. And so they're going to have some work to do.
Yeah, and building on Stephanie's comments and then taking it back to that discussion about what makes it so great but so hard to be a primary care physician, is they're going to bring these forms into their doctor's office. They're going to come in and say, I don't know what this means, doc. And my understanding is that most of the plans have been allowed to put out, here's the price with, here's the price without. And so what we see coming is, doctors sitting in an exam room who would love to be talking about preventative care are instead going to be talking about, what does your premium look like, X, Y, or Z? How do we deal with that? And while docs love medicine, we are not necessarily the best people to talk to about which insurance plan you should go with. We can help, but that's going to be a whole lot of demand on primary care. And the other thing I would point out is like Stephanie said, we have historically seen this. we are at the end of the year. Every doc understands, December is the time when you would love to take a break, but it's also the time when everyone comes in and says, well, I've met my deductible for the year, so, now we're going to be dealing with, and I may not have insurance coming up, so I need to get everything right now. So there's a distinct possibility that we precipitate an access crisis over the next 2 months as folks, just out of uncertainty of what their future is going to look like, stock up on care, for lack of a better phrase.
Sure. Yeah, no, that's, and we're going to have fewer community organizations able to provide assistance. So it's people trying to navigate what to do if they do lose coverage because it's the cost, or trying to just find other options. So definitely a difficult environment. We did get a question about DPCs, and the question is really just, don't they just appeal to healthier populations in general, and leaving vulnerable patients left out of that model? So I don't know
Yeah.
which one of you wants to take that question. I think it comes up a lot in that
Yeah.
just conversation. That's why I think DPC is different than concierge medicine. So you want to take that, Stephanie, or
Yeah,
Dr.
so
Hall?
when that was a concern of ours as well, and also just the smaller panels alone. But one of the things we have been pushing for a couple of years, and maybe the ground is a little softer now to pursue this, but we think that this is an appropriate way for Medicaid MCOs to to extend DPC to the Medicaid population. And so that would be a great deployment of Medicaid assets, to get direct primary care relationships for Medicaid beneficiaries. And so, that's something I think that hopefully they're interested in. It's a defined contribution, what the population is, but all told, whether it's DPC, whether it's concierge, whether it's a rural health clinic, whether it's an FQHC, we have a workforce problem. And so, I think we can shore up the models and the frameworks, and hopefully the financing. But we have a workforce crisis, and so we have to begin to really address those things. And unfortunately, there were some aspects of this bill that chipped away at some of the incentives and the relief, for folks to pursue careers in primary care. And so those are things that need to be addressed simultaneously.
Yeah,
You want to
I think
elaborate on
I
that
think
briefly?
that's a great part. The workforce implications of this are such that there's not going to be one solution. The couple of other questions that we've received just recently were about, what about pediatrics or geriatrics or OB-GYN, some of the fields that may not be as far into the DPC sort of model. You're seeing that in each of those fields right now, but I think the important part is not of, oh, you should do DPC. The important part is recognizing that there's not going to be one solution, but like I said earlier, what got us here is not going to get us there. We're going to have to use that adaptability and creativity to say that, okay, well, in some areas it's a private DPC model. In some areas it's, perhaps a pilot project by a payer or by Medicaid of, we're going to try this in this location. In some areas where we talked about mobile integrated health, rural emergency hospitals, hospital at home, expansion of, use of nurse practitioners, all of those sorts of things. We're in a situation where all of the solutions are on the table to be discussed of, hey, how do we get people the care that they actually need?
So that's a good segue to sort of a regulatory initiative that's underway at CMS, and that is, Dr. Oz, who's a CMS secretary, and Secretary Kennedy are put forth a call for nominees to a new healthcare task force or working group that's going to be looking at a variety of issues. That primary care is definitely part of it because they're trying to improve the way in which we address preventive care and chronic care. And so do you, from what you're hearing about that group, supposed to be named by the end of the year, will these types of topics be on the agenda? How do you address the primary care workforce and the delivery system models and provider types that are going to achieve what they want to do and what will actually advance primary care as an option for more people?
Yeah.
Well,
Or go ahead.
Yeah, if you don't mind, I'll start off from the inside perspective, from the Quality Improvement Organization perspective. CMS lays out what it is that they want to do to provide support to anyone who bills Medicare across the region. And the areas that their emphasis are on for the next 5 years are we're still doing our patient safety, we're still doing our care coordination, but the two areas that they're really looking to expand into are prevention and chronic disease management and behavioral
Mhm.
health. And so that's the marching orders that we have received as the QIO for the area is from CMS to say, okay, this is the area where we really need to focus if we're going to make a difference. And so, from the internal perspective, I can tell you, yes, that's what we're hearing are the topics that they want to talk about and work on. Stephanie, what are you hearing on the other direction?
Yeah, so I mean, applications close September 22nd, or 23rd. And I know that a lot of people, I mean, the city was abuzz with names and who might be named. And, at the end of the day, the individual agencies are going to have to promulgate rules that address some of these things, whether that's the Health Resources and Services Administration, HRSA, around workforce, CMS, whether that's the Medicare physician fee schedule or the outpatient prospective payment system rules, or CMMI. There are models that are looking, and all of those places, they are signaling that they are committed to using their authority to drive better prevention, better outcomes. And so I don't know that a singular body is necessarily going to change that. Maybe it fosters better connection points to hear from outside organizations. But as an outsider looking in, it seems like the agencies are thinking about a lot of the right things, and they're sorting through a lot of the things that we are. And the rules that we've seen so far are encouraging signals. So as far as this group in particular, I mean, obviously my strong bias is that having a family physician who's caring in some of these communities represented somewhere in there, it would be great. But I don't know what they're precisely looking for and what the output is, and what the interplay between the agencies who are working on these things will be.
Yeah, and Stephanie alluded to the Rural Health
Yeah.
Transformation Fund, which, each state
Mhm.
is eagerly and rapidly working to design what they think their solutions are going to be. And while there is the portion of it that is equally distributed amongst the states, I think it's really important to be looking at that competitive side. So what is it that
Right.
we are going to submit as a state? One of the things we're doing at TMF is working with each of the states in our region, basically to share, hey, this is a great idea that Louisiana came up with, or that Arkansas would like to share with folks, and to be able to facilitate those discussions, because it's all well and good when a program is a state program, unless you live in Texarkana. And if you're a doctor on the border, you know that there are patients in this state that go across and patients in that state that come here.
Absolutely.
And so we've got to make sure that we don't lose that perspective of, people go where health is appropriate, not necessarily where a line was painted on the ground previously.
Yes, absolutely. That's a very good point. I also just want to very briefly mention, not related to OB3, but there is this new initiative, the Wiser pilot, which Texas will be one of, which is, as I understand, it's a way to address waste, fraud, and abuse in Medicare. I can't remember the other states that are in the pilot, but because it's coming to Texas next year, um, implementing prior authorization and more utilization review in the Medicare program, the traditional Medicare program. Do you want to talk a little bit about Dr. Cole? I don't know if TMF is actively working on that, but it is Texas as a pilot state.
Yeah, unfortunately, I'm not in a position to talk about that project at the moment, but
I can tell you what
stay
we're
tuned.
thinking about it.
Yes, okay, yes. So Stephanie, please.
Yeah. So, I think we have some concerns. I mean, I think obviously nobody is, we're certainly not championing fraud, waste, and abuse in the system. And I think
Mhm.
it's appropriate to think about ways that we can, make sure we're always allocating resources appropriately. Unfortunately, introducing one of the biggest pain points to physician practice in prior authorizations and a lot of these utilization management processes, on top of the already onerous requirements for Medicare documentation as it is, I see this as going to be an extremely complex and burdensome process for physicians, and I think it's going to create a lot of pain. I think the one thing that I would just flag is, there are vendor incentives in there about identifying these things, and they are
Mhm.
volume based. And I think when you get to that type of incentive structure, it could drive the wrong behaviors. And that doesn't mean it'll universally happen, but there could be vendors who are seeking to, drive up the sheer number of things that are prior auth. And what that looks like in a practice is reduced access to care, reduced timely, appropriate care, medications, all of those things. And so, we've thrown up a caution flag on those things. We joined a letter with the AMA, and really just saying, look, we get what you're trying to do, and there are probably ways that we could innovate around this, but we aren't sure that that this is going to yield necessarily the outcomes that we're looking for without being extremely burdensome to practices.
Well, the pilot, which begins in January, will run for how long, Stephanie? Is it 3 years?
I believe that's correct. Yeah, I'd have to take a look, 3 or 5, I can't remember.
And is it the initiative, is it something that over time, as you get feedback from clinicians about its impact, will they be making modifications, or is this?
Yeah,
We
it's a
don't know.
voluntary model. So people, will go in willingly. And I think that's what CMMI has been really good at. We love the idea of trying things, learning things. Sometimes the failures are just as important as the wins and what we learn from them, so that we can build on that in future models and future innovations. And so it will hopefully yield something. I just hope it doesn't yield. This has completely bogged down and locked up the operation of a lot of physician practices, because that would not be good for anyone, most especially Medicare beneficiaries.
Right, yeah, particularly when their practices are going to be under additional financial strain with
Yeah.
increase in uninsured. So we're coming towards the end. We got about a few minutes left, and it's been a few months since OB3 was signed into law. It's now here. I'd like for both of you to tell us, like, when you think about over the next decade, what is your biggest concern and your biggest hope for the bill, if you
Look,
can.
I'll start, and I know Russell can give some on the ground context, and also through his TMF seat. But I think there's a lot of uncertainty, and as I flagged before, I think the strain on resources, which were already tight, Medicaid was already a very lean program. I think that is going to be challenging. I do think that states have always been able to rise to the challenge when things have been put in front of them. And I would remind everyone that, the ACA, when it passed, looks very different, or up until July 3rd, it looked very different than what was passed. I mean, there were provisions that never went into effect. There were provisions that were delayed. There were provisions that were changed. And so I think, with time, with data, with engagement, with multi-stakeholder connection, I think implementation may look different. And I think layer on top of that, maybe some of the midterm election dynamics, that some of these provisions could change and be delayed. So I don't I don't believe that people should be thinking about every provision of this as written in stone as it is today. I think a lot of this, if you think about, it takes decades to drive forward on a policy agenda, a health policy agenda specifically, and really it was dismantled in the span of a couple months. And so um, it will need to be rebuilt over time. So I think we're looking forward to just continuing discussions about how things are going, and that's when it's very important. And I actually think the rural health transformation fund process that Texas and other states have engaged in, as far as soliciting ideas and feedback about how to solve a state problem, is a great model to really begin to surface solutions specific to states and to hear different perspectives. So I hope that carries over as this plays out.
That's great. Thank you. Great giving us a little bit more optimistic spin on the bill that I know some people in the audience might be feeling. Dr. Cole.
Well, I would just start off with the old saying: in times like these, it's important to remember that there have always been times like these. So, building on what Stephanie said, the world as it exists now is not what the world will look like a year from now, or 3 years from now, or 5 years from now. And what I tend to see historically is physicians somewhat retreating into practice, putting their head down and saying, I will just work harder. What I would say to that is what is really needed at this point in time and over the next few years as this evolves and as it gets adapted and as we are surprised by the things that worked better than we expected and irritated by the things that were a worse impact than intended. What we've really got to do is keep the patient at the center of all of it. Step back and realize that, we may be talking about money or administrative processes or those sorts of things, but at the end of the day, what we're actually doing is determining whether and how we're going to take care of our neighbors. And stepping back and taking that perspective, I think, is the centering aspect that lets you get through all of this. I may not be able to help everybody, but I can help this patient, and I can share the learnings of this situation so that we can make the system better for the next person. And I really think that's where this goes. I try to always, when I was in residency education, used to always tell our residents, you don't have to fix everything today, but you should always leave things a little bit better than you found them. And so it's a less overwhelming problem if you realize that your responsibility isn't try to fix it all in one spot. It's to leave it a little bit better than you found it, and we can bend that arc towards the right answer eventually. And then in conclusion, I agree wholeheartedly with Stephanie that local problems require local solutions. The challenge of applying protocols to patients is patients don't read the protocols, and they may or may not have the exact same physiology as the people in the study. Healthcare problems are exactly the same way. A problem that I see in New Orleans may not be exactly the same causes or solutions as one I see in Lubbock. And so the question is, how do we work with the experts in the communities to get there?
I want to thank you both for a very insightful conversation. We appreciate your time. I know you're both at the American Academy of Family Physicians Conference right now, so taking time to be with us and just the work that you're doing every day on behalf of primary care, but certainly as part of our National Primary Care Week, this is so important. So for those of you who are engaged in social media, please go to the TPCC LinkedIn page if you want to express why primary care matters to you. Or a last reminder to please just go to our summit. It's going to be a great group of panelists, a great discussion, continuation of this for sure, and what's happening at the state level. And also please give us your feedback by completing the survey about the webinar. And so with that, again, thank you. Appreciate your time. Thanks everybody for staying with us on the call and your questions. And we look forward to seeing you next time.